I live and work in north of Sweden, where we have some mines. In fact, we have the largest underground iron mines in the world. Anyhow, it occupies today very few people. I worked as an occupational health physician in university hospitals since the 70s, and during this time I have seen clinically, I would guess something between 5 and 10 cases of silicosis. So it's a quite rare disease for an occupational health physician in Sweden. Anyhow, I will show you figures that it still occurs in Sweden. I will also, during my presentation, give you some idea how difficult the measure of prevalence is and how the physician's role in prevention is more about awareness of the problem than really causing prevention for the single worker. Let's start what we are discussing here. You know that this is how we think about it. We have the dust. It caused some start of a process in our lungs, and exactly how that's happened is still not fully known. Anyhow, we know this is leading to fibrosis in some, and some seem to stand it somewhat better, and why this is different is still a question. Then you can have some preclinical disease, and then you have clinical disease, and some will die with this as the underlying cause of the disease. Some will die with their disease, but perhaps by some other cause. Prevalence as a measure means that we look at the number of persons with the disease and compare with the total number of persons. Mostly it is expressed as percent, as you have recently said from the previous presentation. Mortality, which I will discuss a little also, is the number of deaths, typically measured as some type of during time, and it sometimes can be regarded as some type of rate. If you look in science about prevalences, I made this screen in, I looked on prevalence and silicosis or coal workers' pneumoconiosis, and quite recently you see here, and there was about 1100 hits on silicosis, and about 1/3 of it for coal workers' pneumoconiosis. That's about little less than 400. And if you look over time, you can see it looks like this. There has been some increase in publication, but you know also that there is an enormous increase in publications during these years. These are a number of papers, them are hits, I would say, in the PubMed. And you see also here that it's similar interest in both of diseases over the year here. Anyhow, prevalence is often used to discuss how this disease is changing. This is a picture from a review paper about coal workers' pneumoconiosis. This is the percentage of coal workers' pneumoconiosis among those who have been screened, and it's also divided according to number of years the workers have worked before they were screened. And you can see that it's a slope down here, meaning that it's more rare. This is in US, and then you see an increase here, and it's discussed whether this decrease is real or is some type of bias. But as I will come till sooner, it's a lot of factors that influence the prevalence number. So it's not that easy to understand why it increase or decrease. I know that some of you are not medical educated, so I will say a few words about what we discuss. There is what's called chronic silicosis. Some people call it simple silicosis, but since you can die of it, I would say it's not very simple. Typically, this is regarded as depending on the cumulative dose. That is the total dose of silica you have inhaled or coal dust you have inhaled during your entire life. Then you have the rapid progressive silicosis, which is more depending on concentration. It's things like sandblasting. You can sandblast iron, but you have seen cases sandblasting jeans, where the cases have died at the age of 20 years when they have sandblasted from 13, 14 years, for example. You have tunnel workers working in tunnels with higher concentration. This is a paper just a year ago in the US discussing that there are more cases of this rapid progressive disease in the US in coal workers, and it's still discussed the cause of this. One discussion is that there are higher levels of coal dust. The other discussion is that the coal dust contains more of silica. And if you look for this disease progress, coal dust is, if you test it in animal system, is not very active compared to silica. An interesting question is, of course, is there some safe dose, whether it is a concentration or a cumulative dose? And you can say there are signs that there is a threshold, because silicosis is almost exclusively an occupational disease, while all of us here are exposed to silica, since silica is in ordinary sand, and if you take a walk on a street, there is a small amount of silica in the air. So it seems to be some type of threshold. On the other hand, if you look on science, and I will show you shortly a few figures here, there is no established no exposure level. So it's difficult when you go to prevention to say just go below that level and you will be totally safe. I will show you a few pictures here about the dose response. On this axis, you see the risk of silicosis, and this is on radiography, and that means the ordinary radiography, which most of you have probably experienced. Here you see the cumulative dose of quartz in milligram per cubic meter times year. I will come back to that. And you see 4 different studies here. This is from a review published in Sweden recently. And you see that it starts very early. This is 1 milligram per cubic meter times years. And it's rise sharply here. So when you get up to something 4 or 5 here, you see that approximately half of those studies indicate that they have silicosis. So what is these odd measures? Typically you measure dust in milligram per cubic meter, and that have you been able to do since around the 60s or late 50s perhaps, which you should remember when you look on scientific studies, because many of those people included in such studies have been working earlier when there was no measures or measures of different types, meaning that you have translate measurements over time. But say that you have exposed to 0.025 milligram per cubic meter 40 years, then you have reached 1 milligram per cubic meter. And as you saw from the last slide here, you see that already at 1, there seems, you had at least a suspicion that there is something. Even there is just one curve which you on this slide can't see that something is happening. There is something happened. There is certainly happened. And you see on 2 there is clear evidence. And what about a country like Sweden, which has a reputation for a good work environment, which made severe efforts to eliminate, I would say, silicosis in the 60s, 50s, 60s, putting a lot of efforts mainly on measurements and technical solutions. And what's our level? It's 0.1 milligram per cubic meter, and you see here if you work in this concentration for just 20 years, you have a 2 milligram per cubic meter where it seems to happen things. And there is a discussion going on in Sweden whether or not to decrease it. And you see that for coal dust in Sweden, we have no coal mines. It's 3 milligram per cubic meter. So, and that's quite old. So what about coal dust then? This is coal workers' pneumoconiosis taken from a Chinese study. And you have to be a little careful for coal workers' pneumoconiosis, because coal workers' dust can contain more or less silica, meaning that you have this mixed picture. So perhaps if you are in a coal mine with some silica, the dose response curve would look like look different. But what I like you to see here is the numbers here. Perhaps they are a little difficult to see far back, but here is 400 milligram per cubic meter times years, meaning that the scale of exposure here is quite different. Here we discuss levels that are 100 times higher as a cumulative dose compared to silica exposure. I said something is still people dying of silicosis in Sweden. This is data from the Swedish Death Register, National Register, which is very complete with high accuracy, and it's the number of cases of death on which silicosis is the underlying cause of death. You see the total height of these staples is the total number, and up here is 10, and down here is 3, meaning that the last years here is 2, 3, 4 cases. The other thing here is that there are different colors, and the blue ones, or blue-green, these are people below the age of 69. In fact, they are mostly between 60 and 69. And you see there are quite few of them, that almost all of these people are above their 80s, which are the gray staples here. So it means that if you look for mortality, it's looking very long in time. If you have ever seen a case of severe silicosis, which I have, you will see it's a very terrible disease. Not getting oxygen enough enable you to breathe makes a lot of pain, lot of suffering, and for a very long time usually. They live with their disease, perhaps sometimes for decades before they die. So it's a lot of suffering if you have this chronic form. If you have the acute form or progressive form, you typically have the disease, and then you're impaired very quickly during 1 or 2 and 3 years, and then you die. There is no treatment for silicosis or coal workers pneumoconiosis, meaning that you can reverse the finding. I come back if you can stop the progression a little later, but you can't reverse it. And if you get this progressive form, the only treatment is transplantation of the lungs, which you understand is a very complicated and difficult treatment. And typically, if you are old, when this disease in the chronic form is occurring in more severe form, you are probably so severe ill that transplantation is not a realistic type of treatment, meaning that death is the only thing that's going to happen. If you look for mortality statistics, you have the similar figure. Here is mortality per 100,000 person years. It's a type of rate, but you see also here it seemed to start here, and already in rather low doses you're also seeing an increased mortality. Is this true then? I have been involved in one of these studies, this by Hedlund. It's a study here done in Swedish iron mines. It included both persons who have died with silicosis as underlying and contributing cause, so they can have other diseases also, and that is typically if you look on death certificates. But what you can see here, what I want to show you, is that somewhere here, anyhow, even if the estimation here of the dose is somewhat uncertain, I would say, it is still here somewhere things starting to happen, and you see that even the Swedish threshold limit values, maximum allowable concentrations, are not seeming to protect you if you're working for your full life at the Swedish limit. What then the value of a different type of medical examinations? The classical one is the chest radiograph. It's what you typically go to the doctors. It's you stand there and they take a picture from front of you and on the side perhaps. But there is modern technology which you can do something is higher resolution computer tomography. It's a more time consuming and more expensive thing, and you get a picture like this, which of course you have to be very trained to understand. These pictures are so typical that you even a not very trained physician can understand that something wrong here. But if you go for early cases, it's very difficult. Is there a dose response then? Yes, there seems to be a dose response for chest radiography, but for the other one, there is still no data showing a clear dose response. And doing this higher resolution computer tomography is still not recommended as a standard screening. But the other one is sometimes required. In Sweden, for example, it's still obligatory to do screening if you are exposed to silica, which I think sometimes is unethical. In fact, I will tell you a little more about it when I get back to you in Thursday about that. But let's see. What are weaknesses? Are all with a normal X-ray healthy? No, they probably are not. Are all with an abnormal X-ray sick? It's the other way around. If I would X-ray all of you, would you be healthy on the chest radiographs, and supposing you are healthy? And of course, putting it like that is the answer no. So how do you find out how good is this X-ray radiography? The typical way to do it is look on pathology, meaning that you have to have the lines, and that means that the person have to be dead, and then you compare pictures taken earlier. And there are very few of such studies, of course, because they are rather difficult to do. This is a study from South Africa. It's done, you see, about 30 years ago. It's compare chest radiographs with pathology. They had 3 experienced readers. They studied 555 gold miners, and there were about 3 years between the X-ray and the pathology, meaning that there were 3 years between the death and the taking of the radiograph. And here is a measure, which those of you who are familiar with screening knows what it is about, but perhaps probably some of you not. It says something 0.39 and 0.23. What does that mean? That means that of those who had pathology, the first reader, he detected about 40%, the second reader 37%, the third reader 24% of those. So he missed a lot of them. And this is, of course, how much he missed depended also on how difficult the disease was. Silicosis is not a yes or no. You have a slight silicosis, you have a severe silicosis. And this is for those who have moderate silicosis. These are the yellow ones, and the blue-gray ones are those with severe silicosis. And you see it even for the most severe cases here. They detect something between about a little less than 60% to 70% of them. So between 30 and 40% of those with severe silicosis are not detected by these readers. And you see they are also different, these 3 different readers. So, and you never, when you go to see a doctor, because in practice you are just one reader, and you don't know if this is the guy or that is the guy, or it's a guy with something else, other skills. And the other way around, meaning that you look on those who are healthy. They don't have silicosis when you look on their lungs, when they have died. And you see that the specificity here is 0.98, 65, and 98. It seems to be very much better. Is this good then? Perhaps it's good if you are in a population where silicosis is very, very common. If you do it on very heavy exposed persons, this is not a big problem. But that means that if I would start doing this screening on you, about 2% of you will probably have no silicosis. I will classify as silicosis, which is also a problem, of course. It's a problem in countries like Sweden, which requires people to be screened, which means that we sometimes say to people, you have silicosis, while they don't have it. And that's so with most of medical procedures, that it's not perfect. I will just quickly show you another study, just to tell you this was not the one. There are very few of them. This is also from South Africa. This study found in a sensitivity of 71% and 96% specificity, and typically, depending on design, which groups you examine, etc., you will find things like that. And I also show you a table from this publication. And what you see here is reader 1, and here you see reader 2, and then you would like to see a line here where everything both do the same, but typically when two people are examining something, you don't do the same. So there is differences between examiners, which is not very unexpected, but there are sometimes rather big differences, and especially when you go down here to rather mild cases. And here is also this with autopsy findings, and here is a radiology grade, and you can see here also, you see this scattered pattern. So that's what I want to show you, that it's not a very strict thing, it's a very difficult thing, and you have to interpret it with caution. And here you can also see what's happened. Perhaps you should make a more strict criterion, and then you have here you decrease and you get a higher sensitivity, but at the same time you lose in specificity, meaning that if you try to make it more sensitive, trying to find really all of those who have the disease, that's important for you. You all at the same time start to call more and more people who are healthy sick. So let me show you what's happened in a theoretical way. If you have what's typically in a country like Sweden today, you have it's a very rare disease, and you take 1,000 persons, and you have a prevalence of 0.1%. And that means you have one have the disease, and 999 don't have the disease. And what happens when you start to X-ray them? It means that you classify about 20 persons as sick, who is not sick, and one who healthy, which one is sick. And of course, this is starting to be a discussion about ethics then. And here you have some formula which is common to use, like false positive and false negative. But this is a major problem. So what you don't know here is this finding. Is this due to a poor specificity, meaning that, well, they have these are mainly people who are healthy, but you see it's about 10%, which is a little high to be, in fact, due to just a bad specificity. So prevalence is important. It is important to send out doctors to look at the prevalences. If you want to compare occurrence between countries, industries, occupation, etc., need of prevention or compensation business. I would say, for comparison purposes, it's almost useless, because there are so many things that can influence the prevalence. On the other hand, it's an important thing to do to show that there are sick people, if you have no other way of doing it. Because if you have a lot of people who die of silicosis, you already see the problem. It's not very much of a sense to do a lot of prevalence studies. You have already the body, you have deaths, you already know what's happening. But on the other hand, for example, it can be other things. On the other hand, for compensation purposes, if you go for the insurance company, they are very interested in the prevalences, because then they know how much to pay in the future. Here I have a few things that influence the dominance of prevalence. Of course, exposure, dose, concentration, and time. As I said in one of the previous pictures, some of these diseases are more depending on the cumulative dose, and some are maybe on the concentration. Of course, the criteria for disease, which can vary. You can have different classifications. Prevalence of health examinations. Of course, if you go out and take an examination of the total company, including the office workers, you get a lower prevalence than you restrict your study or your screening just to those who are heavily exposed in the mine. So therefore you can have very different prevalences depending on who you are screening, how you make your screening population, so to say. So physicians, they can over-diagnose, they can under-diagnose. Age of the examined persons. Of course, as you see that you get, it's the cumulative dose that's important. It means that you get accumulation over the years, meaning that it's more common in elderly people. If you're interested in this, I would recommend you to read this book. It's about the history of silicosis. It's historical, and you get the impression, you can see the fight, for example, between ILO and physicians, organizations, and things like that. This is a really interesting book. It's just out of the press, and they are very skilled historians. So getting back to this mental model, what are we doing? For me, it's quite clear that here is prevention. It's a problem for engineers, hygienists, to show the engineers where the important sources of dust are coming from, and to eliminate them and show that the levels are good. But medical screening, we are here somewhere. As I said, we find those, some who have, of course, very minor symptoms, but we are sometimes up here and sometimes very close to death. If you screen for the progressive form, you are somewhere here, typically, if you find them. Is there evidence-based medicine? Is things that medical societies do to find out what is the best way of practicing medicine? And I have looked into if there is any rationale for screening for silicosis or coal workers' pneumoconiosis, but I can't find any. So if you are interested in doing it, you can try to do it to see what really is the gain of it. There is also no rationale for lowering dust in that way, because that's not a problem mainly for medicine. It's more a problem for engineering, for society, for regulative authorities, etc. So my conclusion is in fact that both co-workers' pneumoconiosis is certainly a high dose, and mostly also for silicosis, because in many cases silica is a rather small proportion of the dust. But if you go to a stone crushing place, for example, you will see that sometimes the stone may have a very high content of silica, and then it may be a low dose disease. Prevention is well known. Prevalence of screening of silicosis and coal workers' pneumoconiosis is some complicated measures which you take. You shouldn't, if you see a figure, it's very difficult to compare with something else. So, dust control is what you should do. Screening, you may causing awareness, meaning that people understand that this is a problem. I will say that screening can cause harm. That we teach every doctor. Secondary tertiary prevention, maybe mainly for compensatory purposes, meaning that you give people money. This is pictures from Sweden. This is from the mines. These are miners. They are taking care of heavy machinery down in the mine, about 2 kilometers away, using joystick and screens where they look at the machinery. But still in Sweden you have this, when you're starting in mines, per certain parts of the mines, guys are down there. So of the 5,000 miners in Sweden, something like 800 are working underground. But we still may have a problem because we have metals in our ground that are attractive, and they are starting small mines. I won't say it's informal mining, but it's almost informal mining started also in Sweden. Thank you for your attention. Yes.